It's been an interesting morning. The dentist wanted to join us over here, and I finally had to convince him, no, this was not theirs, it's over there, even if they're from China. So good morning, and I'm glad you've stayed into the room, and we can proceed forward. This session is Innovation and Relationships Drive Success in a Community-Based Care. And it's presented jointly by the Alliance for Home Health Quality and Innovation and the Visiting Nurse Associations of America. Sessions being recorded. The continuing education activity has been approved for one contact hour by the Maryland Nurses Association and accredited approval by the American Nurses Credentialing Centers Commission on Accreditation. In order to receive your certificate, you will need to attend this program its entirety and complete the evaluation which is available on the conference app. And certificates of completion are available at the registration desk right next door, and people have been picking theirs up. Our faculty has disclosed no financial conflict of interest, and I know I've pushed off copies on that disclosure sheet to a lot of people, and it's available at the outside the room if you'd like another one. So we have, it's really nice to see Dwight here doing a presentation. So I'm going to introduce Dwight Wilson first, has been the CEO of Mission Hospice and Home Health for 9 years. During this period of time, the hospice program has grown tenfold. He has been responsible for opening their palliative home care program, expanding their transitional care program, and opening the first hospice facility in San Mateo County. Mr. Wilson has had a long history in innovative program development in long-term care with the Palo Alto's Veterans Administration prior to his current position with Mission Hospice and Home Care. Dr. Lisa Deal is the Chief Clinical Officer at Mission Hospice and Home Care and has been with the organization since 2010. She was instrumental in the development and the leadership of the agency's home-based palliative care program and clinical outreach program and has served as the first director of each. Dr. Deal has a broad background in both nursing and public health with expertise in program development and evaluation. She received her graduate nursing education at the University of Washington and holds a science doctorate in public health from Harvard University. I think we're going to have an interesting session. Thank you. And then I'll let you go ahead.
All right. Well, first of all, thank you. I have to tease my colleague to the right. She can't talk, and she can talk. So we're going to do something we think is a little different. We want this to be interactive. So the very first thing I want to do, Rosie, can I get you to just circulate? One thing that I really don't prepare until like the morning of. And as you know, the VNA likes you to have this stuff a month and before and da-da-da-da-da-da. So the PowerPoint has been updated, and the updated PowerPoint is in the paper presentation. If you want it online and you don't like paper, just let us know and we'll fire it off to you. But so that what you have there is the updated PowerPoint. We absolutely want this to be interactive because we figure if you want to get to the airport at noon and you don't want to talk to us, we can make that happen. But our goal here is to really make this interactive. I think our first question to you at this point is, we'd like to know a little bit about you. And one of the questions is, how many of you are in a affiliated relationship, like with a large healthcare system? Just hand. How many of you are still independent? Ooh, good.
That's good.
Because I don't know, we just were in a presentation before us, and it seemed like the whole world is consolidating, and there's like a big rush, and that's sort of, second to the coming of Christ. That really is what everyone's supposed to be doing in the next year or two. And what we want to do today is really talk about what we feel has been an effective strategy in maintaining our independence and yet being really aware of what's going around us. The San Mateo area is dominated by large healthcare systems. We're dominated by Sutter, whose model is essentially we do everything, and there's Kaiser, very similar model. We have Stanford University, and we have UCSF, and then we have 2 or 3 smaller systems. And all of these systems are buying out private medical practices. So if you're a young physician today wanting to start your medical career, you're not going to open up a private practice. You're going to become an employer or employee of one of these large systems. And so we work in the environment I think many folks work off of. And what we'd like to do today is provide the foundation of what has guided us and to interact with you. And Lisa, who really is sort of she's really the role model of how we have evolved over time in such a way that has made us effective. So it's really important that she speaks to her capacity before her voice goes out. So in essence, in our slide, I just got to do the slides here. I told the guy who was the PR, the person that does slides, he's about my age of my grandchildren, and I told him that he's got to make it a way that it works. Oh,
It's supposed to work.
it's supposed to work.
Or it said that here comes the other one with more gray hair.
Well, this is age discrimination, so I
Go to the paper one.
okay, well, we're gonna go to Plan B. So on your paper, I don't know what's going on, I don't care. On their paper, I'd like to take you to the page that says mission, this page 4. It looks something like, starts with community-based nonprofit in San Mateo County, okay? And
Here we go.
how'd you make it work?
Well, I'm just pushing this.
Oh, okay.
Okay, now the-
Well, I'm kind of
oh,
giving
here it is.
one more. They don't care about learning objectives. There we go. There we are. Okay. So the what's driven us, so for a couple things.
It worked, yeah.
All right.
There we go.
Fair enough.
That one.
That one? All right. So when I came 9 years ago, we had 25 patients, and we did hospice. And it was quite clear that at that point in time, we're going to have to do something besides take 25 patients, otherwise we wouldn't be here. And basically what we decided to do is become a mission-focused entity and looking at what are the needs for end-of-life care in the San Mateo County area. And it was really clear at that point in time that hospice in and of itself is not enough for people who are looking at their last year of life. It's just not enough. And so what has driven us in this whole period of time is developed a mission of who we are, and we decided that our mission was we were going to be the resource for our community, for individuals and their family facing the last year of life. And we were going to populate our programs in such a way that would take us to where we are 9 years ago to where we are today. So mission-focused, continuum of care, and 2 other things that became very important that I think drives where we are today. One is quality of care. If you don't have quality of care, you might as well just forget everything else. And the other one, I think, has to do with responsiveness. You know, the old days in which the meaning of our nonprofits, you shut down at 3, you woke up the next Monday at 8, and oh, okay. I guess I'll sit down. And all of that just wasn't going to work. So responsiveness, quality of care, and being that resource for the last year of life. And then the 2 other things that we expanded on was becoming a community educator for this that was recognized as a leader. And then the very last thing that we chose to do and have maintained to this very day is we're the employer of choice. And a good example of that is our staff turnover rate is approximately 10% a year, which in our field is pretty phenomenal. So that's where we came. And I think the other approach we've taken that really has been a focus of who we are is our approach to anyone that asks about us or care is, what are your hopes and dreams? The very first thing that out of our staff's mouths when they engage anyone at the point in time to us is their hopes and dreams. So instead of coming up and saying, you know, here's what hospice is all about, or here's what palliative home care is all about, or here's what our transitions program is about, or here's what our hospice houses, which we all now have. The question is, what are your hopes and dreams? What are you hoping for during that period of time? And what can we do as an example of that? Have I missed anything?
I don't think so.
You want to say anything?
See how long my voice holds. I've never had laryngitis in my life, and then I got it now. I just want to say one thing that, you know, we feel like our growth and success has really been all about relationships and people and building those relationships. It's our relationships with families and patients. It's our relationships with our physicians and our referral sources. It's our relationships with our community partners and the agencies that we work with. And lastly, it's our relationships with our staff. Someone in one of the lead presentations yesterday, I wrote down a quote that said, as leaders, we care about each other. And I think that's so true for how we have kind of developed our philosophy of how we run our organization. And Dwight is really an example of emulating this. And that he really, you know, he talks about hopes and dreams with patients and families, but it's also hopes and dreams with the staff, and evolving staff in a way that that they really feel valued in the organization has been very useful for us.
Not bad. Questions, comments, thoughts? I mean, how about you guys? What have been some of your challenges kind of, you know, trying to, you know, to carve that independence in the world of giants? Someone's got to speak up. Yeah.
Keeping staff, finding the right people, but then retaining them. Our turnover rate is not 10%. Much higher. Is that maybe some of the things that you did to achieve that?
Yeah, we staff in our organization have we promote staff from within a lot. So we really work with the staff to be able to look at kind of what they want. For instance, I have one of my nurse managers recently who's been a nurse manager for 15 years and came into my office and said, you know, I'm kind of tired of doing this. I kind of feel like I'm bored. I do the same thing all the time. And so we talked back to the hopes and dreams about what her hopes and dreams are, and what she really loves is training and education and being a mentor. And so when we started looking at our programs and how we train our nurses, we realized that there was really huge opportunity there to do a lot more. And so we created a new role for her and moved her. She's starting next week, and in fact, is a senior nurse educator is what we're calling it. And she's going to really develop a preceptor program. We're seeing, too, that we're getting a lot of the older hospice and palliative care nurses are retiring, and we seem to be getting a lot of new nurses. So we've realized that through this, we really have to train our new nurses much better, so her program will do this. So that's just kind of one example of how we move people up. Another thing that we have done that's a little less direct, but I think has made a big difference for our staff, is we do staff retreats every year. Every department has a retreat every year that really looks at their goals as a department and the goals of the individuals. And Dwight and I attend all of those retreats. So kind of January through, we have a few more. June, we end up doing a lot of retreats, but it's really been a time for us to be able to hear from everyone in the organization at some point during the year and really have them share sort of what they're hoping for, what they're looking for, and developing their department goals together that I think has been successful. You think of other things?
Well, I think the thing that I'd like to do, as long as your voice is working, Lisa is almost the poster child for how we bring quality people on. We're, interestingly enough, healthcare entities tend to basically eat their young and also eat people that are really quite good. Rosie, who's here, who's in charge of our ACP, came from another system. How were you treated in that previous system?
Very poorly. I was a manager or supervisor there, and I was told how to supervise. I was not allowed to supervise staff the way I felt they would need to be supervised to grow. It was like a can management type of program.
Okay.
So I'd like Lisa to just talk a little bit about how she came into the organization and how her role evolved. Actually, is how our agency has evolved over particularly the last 5 or 6 years. Sorry.
Doing it again. Well, it's been organic. I would say I like to say that we're strategically responsive, that we look for opportunities both out in the world and within our staff to grow. So I first did home health back in the 80s in Boston and had a lot of AIDS patients and got interested in hospice at that time. And then fast forward through different career moves and raising my children, I decided to go back to work in my mid-40s, and I really felt pulled toward hospice and palliative care. I'd lost my father and my dad in the previous couple years and just wanted to explore this. So I actually started out, I went through the volunteer training program at Mission Hospice, and when I was in that program, I talked to the director and said, I'm really interested in doing more. I really think this is an area that I could grow and thrive. And so he said, okay, why don't you speak to the CEO? So Dwight and I met, and we talked about different roles in the organization that might fit with my skill set. And he gave me the opportunity to do an internship. I was coming out of 7 years at home raising my kids, so I kind of needed to get my nursing skills back up. And so I started an internship, and shortly after was hired as a nurse case manager. At that time, the home care program, which Rosie runs now, that has a census of about 95, had a census of 4. And we were just kind of getting started, and Dwight realized that he needed some direction and leadership, so he asked me if I would step into that role. So I knew, I knew a little about home care from doing it, a decade or so before, but I had never worked in a leadership role in a home care agency. But we together, we really worked. We put a work plan together, a staffing plan, and we started building up our patient base. And then once the program was fairly well established, I think we had about 20, 25 patients when I left that program and turned it over to someone else who then turned it over to Rosie. We were looking at ways we were outreaching in the community and realized that we could be doing some more creative things and being more responsive to our referral sources. And so Dwight, again, he's good with the ideas, and then he gives them to other people to figure out how to make it work. That we wanted to start some kind of outreach program to our referral sources in the community. So we developed a program, a clinical nurse outreach program. All of our outreach is done by clinical nurses in the organization that are experienced in hospice and palliative care. These are all nurses who have come, speaking of, kind of coming to a place where they want to stay in an organization. A lot of them have been case managers or managers in some other environment, and they've really wanted to come and stay. So they're really the face of the organization to the community, both the physicians and oftentimes to patients the first time that they go in and introduce themselves. And so I rolled into the role of developing that program and leading it for a time. And then since then, we've kind of evolved in our relationship and in leadership and thinking of transition planning in the organization.
Okay. Just out of curiosity, do you have a hospice house?
Yes.
And do you have, how is the management structure in terms of, say, a home team versus a hospice house, or how is that leadership integrated?
Okay, so let me talk a little bit about how we manage patients that transitions from one program to the other, and then I'll get to your question, which is the leadership one. We believe in a seamless model, so if a person comes to us in ACP, let's say in third and fourth line chemotherapy, but still needs palliative, essentially symptom management, and then transition to hospice, the team that's in home care will follow them into hospice, so they'll keep their same team going forward. So our management model, while we do have distinct categories, and Rosie is an example of being the lead in our ACP program, the patients, it's seamless. So they'll have their team follow up until the hospice house. Now our hospice house, and I've got data in your sheets there if you go through it, we opened the first hospice house facility in San Mateo County back in October of 2015. Now, some of you who are in other parts of the country, like Kansas City has like 10 of them in the city. California is a strange bird when it comes to this. There's very few inpatient facilities out there. The other thing about our hospice house is the model and how we're doing it is, in fact, we know it's unique. We essentially bought 2 residential care homes or board and care homes, however you wish to call them, and we essentially run off the residential care license, and then we manage our acuity under the continuous care model under the hospice benefit. So we have a 10-bed facility in San Mateo, like I said, that we have purchased and is functioning. Actually, it'll be fully functioning in another month once the renovation is done. And then we have just purchased a second residential care program down in the south part of San Mateo County in Redwood City. So we will be, by the time November shows up, we'll have 16 beds in that program. In that program, we have co-directors. We have a medical and a nurse who are co-managing it. And then we have the LVNs 24/7. We're probably going to supplement that with RN coverage because we're also embarking on a contract with some of our hospital systems that are looking for that RN 24/7. Did that answer your question? I mean, it's quick, but and a lot of the data in the program, and you'll see the census and some of the, it's halfway through there that you can glean and look at as you will. So far, that's what we're doing. Any other questions before we go? Yes.
I'm just curious about the retreat that you have for your teams. Is that something organized by the team manager, nurse manager? Is that organized by you? How do you define the topics and the flow of it? Sometimes you get into a team and they want to talk about the things that bug them, like productivity expectations of staff and things like that.
Yeah, so it's kind of interesting when we started these. This is our 3rd year. We sort of thought it would just be an interesting and fun thing to do. So again, very organic. We didn't have a set agenda for each of them. But the first couple of years, Dwight and I really led the retreats, and we looked at programmatic goals, individual goals, opportunities and challenges, successes in the organization. And this year, we've asked all the managers and directors to lead the retreats themselves. And we do this from everyone from our administrative support staff to our senior management staff. And they have, over the years, we've found that people are feeling more and more free to share kind of what they're really thinking. And they're now feeling more like retreats, that people are really taking time sort of out of the workday. Sometimes they come in sweats. I do a lot of them at my house. We always include a nice meal and a really time to retreat and bond as a team and to try to do exercises. Some of them do meditation exercises that really feed the souls of their staff. So, Rosie, do you want to say anything else about the retreats?
Basically, we're not given a theme to discuss. It's totally up to each department what they want to focus on. So as a director, I work with my clinical manager and discuss and then present to Dwight Wilson. This is what I want to focus on. And this year we focused on our palliative certification and, what that meant to the staff and how we can help them with this. And, for this meetings, I've already jotted down ideas for next year's retreats of how we want to progress. So there is, to answer yours, there is not a set topic to discuss. It's open-ended, and each one, because we know our staff, we know what their needs are.
Another example of building up our staff that we've just recently are embarking on is we have a director of education and quality, and he, again, this is another example of kind of our organic process of developing people, that he said he was really interested in doing coaching and leadership coaching within the organization. And so we actually sent him to a week-long program, and I think I'm not even sure what it's called, strength-based coaching approach. And he went and basically trained to be a trainer and come back and do strength-based coaching within the organization. So we've started just implementing it, and all the managers are going through it first. And the way the program, it's one of these sort of personality test type things, but you get your 5 strengths. And now he's meeting with all the managers, and they have their 5 strengths. Everyone's done this up on the wall in their room. And so when they have issues with other staff or are thinking about moving forward, we really try to draw on their strengths and look at how they interact. It's been kind of fun.
So let me just, I know what these microphones are for, so I'm going to use it. I do want people to realize that we're not sort of ad lib, laissez-faire, hope the hell the world gets through. So in the vision, then what we are very disciplined about our, oops, am I going the wrong way? God, good Lord. Okay, this is clearly, I'm going to file a complaint about age discrimination here. This is, so we have, this is called I've been hit by many purists because the strategic plan is supposed to be like a 5-year plan. Well, the bottom line is I can't think beyond a day, let alone a month, let alone a year. But so I compromised that we do it a year. So our strategic plan is a year. And we've got a community-based board, and this is a very interactive, actually is my evaluation. Is what it ultimately turns into. So there's a lot of investment in me just because, I like to have a good evaluation. But more importantly, it's an investment in the relationship between the board and leadership. And this impacts these retreats, although we don't bring these into the retreat as an agenda, but we use it as, what are the priorities what are the goals for the agency for the upcoming year? And we really work hard to stay focused. And so you'll notice that maintain high quality of care. I mean, that's one of our goals. And what we try to do in that is identify what does that mean? And I'm not going to read it to you. You've got it you can read that. And we try to make it measurable. What are we doing to track quality of care? And there's some fun stuff there, like that very 4th one that I'm sure all of you deal with. How in the hell are we going to make our EMR work that we like? I mean, we've been through several transitions of that, and so there's that. So there's the quality of care one. In the next page, if I can make this work, oh, I can't. We have financial targets, like everybody. You got to end up whole. And so you'll notice we have, the quantitative outcomes. And, we also have a fundraising section. And we have a capital campaign. Our first hospice house, we're in a $6 million campaign. And we've raised just under 5, and we want to close it out this year. So it's in the goals. And then there's administration, we had to make some changes in how we for our exempt and non-exempt staff. I took some liberties on keeping as many people non-exempt as possible or exempt as possible, and we had to adjust that, so that's in there. And there's the retreats, and the board is what we do from these retreats. We collect all these. Actually, Lisa does, and I report out, and then they're reported back to the board. And so these are, and then audits and joint commission and things like that. And then there's our hospice house. It gets back to, and what's beautiful about this plan, when we developed this strategic plan last year, Redwood City, our mission, our second facility, we weren't even thinking about a second one. We had some of our advisory committee say, I've got this facility down in Redwood City, are you interested? And so we're focused on the strategic plan, but we're open to opportunities. And because of the success of our first facility, we went ahead with the board being really involved, and now we have 2 hospice houses, even though it wasn't in the strategic plan that we would open up a second house. It just grew organically. And then, of course, there's always the issue of the board of directors and a goal for them. And like I said, we're really good about 6 months. I've got to report back as to where we're at. The anticipation is that some of these goals we may not make it, and others we may add to it. And the ultimate goal for all of this is to keep the board myself and the overall agency in a communication plan that's consistent throughout the organization. Any questions on that? I mean, this is not particularly unique to anyone, except I think we try to focus it much tighter in a time frame that we feel is real.
What's the, in formulating the strategic plan, what's the role of senior management, so to speak, and the board in that process?
Well, the role starts with myself and Lisa, really, as sort of putting our thoughts together. And then we have senior management, includes our HR and administrative officer, comes together. And from there, it goes to our executive committee on the board of sort of emulating it through. This document takes us about 5 months to get through. So we do the first rendition. I've got 2 board members who are so outcome-oriented that I'm pretty outcome-oriented, but I can't even compete with the 2 of the board members. So I come up with my dream and say, oh, well, that's fine, but what the hell does that mean? So we go through a lot of that, and then it is, and then the top leadership is also being kept informed on this, and then we'll actually update it as we update with the board. So the top leadership is absolutely in sync on this. I don't think we've ever done a strategic plan that we've been in conflict with the top leadership that I'm aware of. And the beauty of this, that this is not a straitjacket document. It is a document that is our best guess as to what we want to do for the upcoming year. And then what is asked by all of us is if we're making adjustments, as we will, we make adjustments, like the second hospice house being an example of that.
Regarding the freestanding hospice house with general inpatient care, how large, how many beds?
So we have 10 beds in San Mateo, and we'll have 6 more in Redwood City. We've had, like I said, half of them in and out because of renovation and all that. We are heading in the direction of looking at the 2 houses as one, even though they're 2 locations. And we're doing that in part because of our relationship with our organizations that are asking to have contracts with us. And we're doing it because it also drives how we hire staff. So staff are being expected to be able to float between the 2 facilities based on acuity and other issues that relates to 24/7 staffing. So that's what we're doing. And these models are based on a 85% occupancy and about a 7 to 10 day turnover. So these are high turnover programs. They are based, I don't know if you folks are familiar with these social models out there where there's where they claim they don't charge anybody anything, but they really do. So what we do is people that come in, I mean, we get the hospice benefit for providing hospice care as an agency. And then for the per diem and overnight costs, we ask families just one question: what can you afford? And then they're paying about 50 cents on the dollar.
Do you have hospice beds in any facilities?
We have GIP contracts with one of our hospitals. And the beauty of these houses is that about half of the folks that are go on GIP will transfer over to, you may want to say something too.
I was just going to say, our hospice houses are really, they're not for long-term residential care, they're really for very end-of-life care. So our average length of stay is about seven days. The GIP mentioned in here, we're also, in addition to these 2 hospice houses, we're in discussions with our county about finding some land to eventually possibly build a larger entity. But we've kind of gotten stalled in that, so we're not sure where that's going to go right now.
So I just put out the slide that you have on paper. This is the demographics of last year. And like I said, it's about halfway through after your HCP or transition program, I'm not sure which. So this will give you a flavor of the evolution of this. And there are 2 slides there. This is for 2016. This gives you a little bit, we have 2 healthcare districts in San Mateo County that actually provided us funds. And so they are very territorial that we report out as to whose patients are being served by whom. So that's why you see that. And again, to Lisa's point, you'll notice her length of stay. And you kind of notice our age demographics. This hospice house is, we're finding, which we probably anticipate, we've served individuals as young as late 20s in this facility, even though most people who were there are older. But
One thing we love talking about our hospice house because we're so excited about it, and it's been such an amazing success. But one of the amazing things about the care that we're able to provide there is we've had 106 deaths since we opened in the hospice house, and I can honestly say we have not had one complaint from a family that their experience wasn't just beautiful. So not all deaths have been easy there. We get very, very acute patients, and many of them are very hard. But the families feel so supported, and their loved ones get such beautiful, beautiful care that it's really been incredible.
I mean, we really want this to go back and forth. We can bounce around these slides any way you wish. So,
I'd be curious on any of your experiences in these areas too. Anyone has anything they'd want to share?
okay. Let me, the area that I want to re-emphasize the landscape of our environment, and then if Lisa's willing, I want to talk about our community education program. Again, the Bay Area is dominated by these large healthcare systems that I've already mentioned to you, and most, if not all, new medical practice are being bought out by these large systems. And so one of the biggest concerns, other than value-based purchasing, as however that's being defined, and the bundling and everything that goes with it, is our biggest concern 2, 3, 4 years ago was that as this continuation of these large systems, they just wouldn't refer to us. They would just shut down. The Sutters would refer to themselves. Kaiser would contract out, as they usually do whenever they don't want to do something. And Stanford and UCSF would affiliate in such a way that they would basically dominate who they wanted to refer to. And we've seen examples in our own area. There used to be a hospice program called Hospice of the Valley that was purchased by Sutter, and they as an entity are essentially gone. So we were anticipating we would be seeing a big change in our demographics. And the other thing that we were concerned about was our ACP program, which is a palliative home care program. We designed that to be palliative. It is not designed to be therapeutic, hip fracture, in and out kind of program. And that's a challenge for us because that model does not make money. I think the presentation before us talked about that home care programs tend to be money losers, and that's a challenge for any entity that is trying to remain independent, because if your dominant business is a money-losing entity, it's hard to survive. And for us, ACP does not, we do subsidize it, but it has enhanced our capacity to serve that last year of life. And what we have found is even if physicians and the referring folks are part of large systems, they still want quality of care for their patients. And what we have found in our local environment, and I don't think is unique to us, we have found that in large healthcare systems in general do not prioritize the leadership capacity of those individuals providing home care. They just don't. And so therefore, the ability for some entity like us to be flexible, responsive, and develop new programs in a way that meets the needs of those referring agencies has been huge. We can do same-day service. We developed an in-stage heart program that's not part of the bundled model. And in part, it works because this is an individual, and she happens to be my daughter, so I can brag about her a little bit. But she's an individual who knows how to engage the physician referring base in fairly complicated heart failure patients. And a good example of that, she said, the part of best practice in heart failure is they've got to have these socks. But she says, 85% of these people can't pull out these socks. They just can't pull them up. We want to pull up these socks, and they can't pull their socks up. So they're developing a very unique system on how people can get their socks up. And we're supplying the little tools to help individuals to pull up the socks. Simple stuff. But I would argue that you won't see that kind of creativity in large healthcare systems because it's sort of outside the norm of what their management staff are allowed to do. And it has worked. And, you know, will it be working 5 years from now? Who knows? But to date, we have a very effective relationship with the palliative care group down in the Palo Alto side, south part of the county, who is part of Sutter and who they're under pressure to refer all your folks to them or elsewhere. They're coming to us because of our quality of care, our expand, and now we're looking at possible contracts for the hospice house because it serves their patients in such a way that enhance their quality, which then they can utilize as an example of how they give quality care. We're in contract negotiation with Stanford. Now, I don't know what you all know about teaching institutions, but one thing they don't say, come to Stanford because we have the best end-of-life care. No, they get folks that are coming to Stanford because they want someone to do everything possible to keep them alive in the most innovative practice. And then what happens? It doesn't work, and they have these very complicated family and dynamic in their hospital and have nowhere to go. And now the relationship is how can we enhance the quality of our care with us in something they can't do. Now they're having to realize that maybe they don't know anything about this, and having to work with teaching institutions to bring the two cultures together is a bit of a work in progress. But that being said, this creative, innovative model of care that focuses on quality of patient outcomes, we strongly believe that still works in this emerging healthcare system. And our numbers at this point supports that. And who knows? Already we're starting to see with the new administration that maybe these large systems won't be as supported like they thought they were going to be, or maybe we're going to change the model of reimbursement, or maybe, those of you who lived in the 90s when the HMO thing took off, that was going to be the new thing, and it lasted 3 or 4 years and sort of went into different models. So we're trying to maintain this visionary process in such a way that it drives us. And I think the last thing I want to end up with is back to Lisa, is about part of this is our community education, another endeavor on how we're outreaching to other entities that is not traditionally something that home care and hospice agencies do. So if you're willing, Lisa, you've got the voice.
So we decided a while back that we wanted to be both provide the highest quality of care in the last year of life, but we also wanted to be an education and resource for people on end-of-life issues in the community. So we actually hired a woman who spent about a decade in England and developed a community education program there to come in. And we wanted it to be a very grassroots kind of bottom-up approach because we felt like it was really important that we have the buy-in from the community. So we've started in 2 pilot communities. One is a coastal community in our area that's quite rural, and another is a much more kind of suburban area. And we've gathered, we've gathered players from several of the organizations there that either serve the elderly or serve the disabled, that serve anyone who may be kind of more vulnerable with chronic illnesses and toward the end of life. And they've really talked about what the needs are in the community, and have developed a campaign in each of the communities to go out and do workshops on end-of-life discussions and moving those discussions further upstream. We've also developed a movie series and speaker series on end-of-life issues that we show out of Mission Hospice. And we were part of a grant from the Hospice Foundation of America to show the film Being Mortal to different segments of our community, and then to hold kind of panel discussions around that. So we're super excited to be kind of partnering with these community agencies, and we're hoping that in the long run it's a good business strategy for us, and that it'll grow our presence in the community. But we're also just doing it because we feel like it's critical for us to be able to be part of those discussions of moving end-of-life conversations further upstream, so people aren't having them for the first time in their doctor's office at really critical times.
Example of a so who would know that the Alzheimer's Association does no end-of-life education? Who would know? They don't. So one of the relationships that we're building is when we met with them on end-of-life support for the Alzheimer's Association, never entered their mind that this would be something that they should be really thinking about, because they're really so focused on supporting the care of the Alzheimer's individual in the home that it just never entered their mind. And they have grant resources. And so we're now looking at a relationship that will, the expectation was that, you only need end-of-life support when the person's barely able to breathe. And now we're looking at what are the resources that can be given to families during that last year of life. And as we all know, in cognitive the illnesses, that's a very, what does that last year of life mean? So don't focus so much, just best guess you're getting to your end stage part of your Alzheimer's. We all kind of know what that means, sort of, but we don't have to define it. And then the relationship of having to provide end-of-life support in a relationship with Alzheimer's that talks about cognitive capacity, caregiving support, and all of that. What a beautiful synergy. And, there's a lot of these specialty organizations, the Lou Gehrig's disease and their groups, and, you can just go down the road, and most of them are not focusing on end-of-life education. They're focusing on how to manage disease in such a way that keeps the family whole, and they just kind of haven't thought about that. So this is an opportunity where the community education, not only does it enhance, what we're doing, but it enhances what we feel is a solid business model for our capacity to continue to emerge and grow what we do to people who otherwise would never even think about this end-of-life care where we do. We didn't mention that we have a transitions program. It's in their stuff over there. Again, we said we wanted to be that last year of life. Well, there's home care, it has a benefit. You have to meet the criteria. And there's hospice, and it has criteria. And then there's folks that sort of don't meet the criteria already, and that's where transitions is. And that is a social model where we have a social work and volunteer support, and now we've incorporated it with our outreach and some of our nursing staff once a month call-ins to make sure things are going well. And that's, again, looking at community support, that last year of life, that flowing in, individuals not being dropped out of the system. And it is not unusual that every week we get a call from someone in transitions that's changed, and they know us and they call us, and we're able to put them into the program that's appropriate for what's going before them.
So it's interesting. Last year of life is as a target audience, so to speak. I don't know if that sounds quite right, but anyway, there's lots of. It's very problematic finding out hospice in 6 months or whatever it is. So, what do you do to help people on the outside identify patients that might fit into the last year of life program, or that's just not a designation that I'm particularly familiar with?
One thing that we do, because we have our 3 programs. We have our transitions program, our advanced care program, which is our home-based palliative care, and then our hospice, is when the outreach nurses go out and are talking to physicians and referral sources in the community. They're really just saying simply, if you have patients that you feel like are kind of in that last year of life, don't worry about what program they're going to fit into. Just let us go out and talk to them. And so then they have the initial interaction with the families and the patients to talk about their goals of care, to talk about their hopes and dreams, to talk about their symptom burden that's going on. And then they can kind of define how we can best serve them. Because like Dwight said earlier, our programs are really seamless. So if a patient starts in the advanced care program, and then when they transition to hospice, they keep the same nurse, the same social worker involved in their care. And it makes it a lot easier for patients that they don't have to think, I'm going in this box, but just kind of, we'll figure out what box you need to go in, but we'll provide you with a seamless level of care. Does that answer your question?
Yeah, in a way. I think I understand the seamless care, but it's
Yeah, let me try to answer it from another vantage point. Most people who are facing that period of time are so stressed, so pressured, and this last year's stuff, it probably doesn't mean much. I think the challenge for addressing, and then we got, I don't know how old you are, I'm 68, and we're the most narcissistic generation to come to this planet. So we have a very narcissistic population that is coming to us that wants everything done, and they don't want to pay for anything. So we've got this really challenge before us and scared. And the idea that we're working on is we're really de-emphasizing the terms home care, hospice, and all that, because most people think hospice is hopeless and giving up, and there's some cultures out there who feel that when you mention hospice, well, I'm not getting any more resources, and all the baggage that we deal with in this last year. So what we're really saying to people, if you are looking at serious issues in someone who's declining, we can figure out the last year when we talk to them. It's really getting them to talk about what is going on and what are you hoping for. And, like with hospice and home care, often they'll end up in ACP because they figure hospice and hopeless and we don't get squat is what you get. And once they gain the trust, then you start looking at what's the best benefit for you, what are the best resources, how can we help you, what are the issues facing you. And this last year and 6 months and all this other stuff that we have to worry about on our side, because that's how we get paid, is no longer a problem from the consumer. And that's the real way that we address it. So we say last year of life so we don't get people coming into child care, but I mean somewhat, a little more facetious, but it's really not that important. It's really, if you came to me and let's say your wife was just declining and you were just fit to be tied, and all we would say, well, let's just chat. What can we do? Let's look at the resources that are before you, and then the rest will evolve over time. And 90% of the people who call us meet the criteria. In fact, probably 98%.
The beauty of our transition program is it is all community funded and grant funded, so we don't have to, we're not beholden to, if ends up being the last 2 years of life, that's fine. So it makes it easier in that way.
Actually, when I was CEO, we went for some grant money and we called it Living with Cancer. And
Okay.
what we did was train some volunteers, very well, good, and the nurse would call and do a home visit or something, so that once the traditional home care was finished and we could no longer go in, we switched them to that program, kept track of them, and then took them back in as they declined. So there's ways to do it. I love the way you called it, the transition program. But you gotta get the separate.
Yeah, you do. Although it's not a hugely expensive program. I mean, we have a $23 million budget, and I would say the transition program costs us about $300,000, and we get grant funding for about 40% of it. We write specific grants, but so it's not. If that's your biggest problem financially, your agency's probably in bigger issues than just that, if you know what I mean. And it provides the confidence of the community that you're willing to be there for them through thick and thin. You're just not going to drop them because they didn't meet some required program requirements, and that is huge for a lot of folks, particularly those individuals who resources are a bit tight, which, as you know, in many situations that can be as much as 50% of your population, if not more. So we have, I think, 5 minutes? So other questions, Q&A, issues? Did we miss anything? Were we in a pipe dream? I mean, then I think what I'm going to do, I don't see any reason why we can't let you out a couple minutes. I just like to take you to our summary, which is the very last page, and is really based on what we really feel has worked for us. It's us. We might be unique, but I hope not, because I fear someday that entities like us won't be around. But I do feel we really have to identify who we are, what's our niche, and maintain the quality of care that we've talked about. This employer of choice is so important. I'm surprised the people that work with me have stuck around with me because I tend to bounce with my ideas quite a bit. But in return for that, the individuals, and Lisa and Rosa, I hope, well, with having their eyes go into left field somewhere, they have total freedom to manage and also come back and say, the dreams you came up with yesterday, I think we can just let that one go. So it really is about quality individuals, I just can't emphasize it along. So our bottom line is healthcare is still local. Every time you and I go to a provider, we really don't care who that is as long as the quality of care is there. And the bottom line, it's relationships. The relationships that I think sometimes we see in this modeling, they think the institutional relationships are critical. We've done almost all of this not through the top management of the healthcare systems. We've done this with our direct case relationships. So I've talked to CEOs, but I have spent probably 2% of my time. This has all been person to person to person relationship, case managers to case managers, provider to provider. We have our medical staff is much higher than most entities. It's relationships, and I would say primary relationships. CEOs come and go, but relationships stay, and so that has been really, really, really important. And then I think the enhancement of our community partners that Lisa articulated, the idea of looking at all the organizations around us that are really struggling with the same thing that we are a resource to. And I think that's going to be a gift to us as we go forward. So with that, I want to thank you all for staying with us for the hour. And I want to thank Lisa for using every ounce of her voice, and Rosie for being picked on. I don't think she was anticipating that.